This clinical resource is on central venous access devices and specifically occlusion prevention and management. This here is an example of a CVAD. This is a lumen, so this CVAD in particular is a triple lumen. They can be single, double, triple, or even quad lumens. And you can see on the left-hand side there, that's actually what the inside of a CVAD line looks like, depending on how many lumens there are. So it means the drugs can actually be administered at the same time through different lumens, and they won't actually interact with each other because they're going through different sections of the line. This here is a clamp. So you want to make sure it's open every time you are administering medication, and you also want to make sure you clamp it shut when you're not using the lumen. This here is the securement, so you can either have it sutured into the skin or you can secure it with a stat lock, just depends. So this is the catheter tip, and it's a soft contoured tip to reduce any harm to the veins or aggravation to the veins, and it's nice and flexible. And you can see on the left hand side there's actually different exit points for each lumen, so they exit the catheter tip at different lengths so that the drugs won't actually combine and cause any adverse reactions. So this is an example of a CVAD which is interjugular, so it's going into the jugular vein. You can get them subclavicular, and you can also get femoral or PICC lines, which are peripherally inserted. So this here on the end of the lumen is called a bung, or a needleless connector. And this is a little impregnated sponge with chlorhexidine, and that just stops any infections. And this is a stat lock, so that's a securement device, which you may see on certain CVADs, but not all of them. So occlusion is one of the most common complications of CVADs. Around 25% of all patients who have a CVAD will experience an occlusion. So it's really important that we maintain our CVAD using the correct policy and procedures, and this can help maintain patency. So an occlusion is a partial or complete blockage of either one of the lumens on a CVAD when aspirating or injecting. So it can be defined as the inability to infuse or inject through a central venous catheter, inability to aspirate blood from a catheter, or both. So there are three types of occlusions that can occur in CVADs. So the first one is mechanical. It might just mean that there's a kink in the line somewhere, or that it's actually clamped off, and it can also be positional depending on how the patient is lying down or sitting. It might just be putting pressure somewhere on the catheter that's blocking the line. The second type of occlusion can be precipitate or chemical. This can be a drug or chemical incompatibility or interaction. It can also be a lipid residue from TPN, for example, that builds up in the line and blocks it. The final occlusion type is the thrombotic type. So this could be a blood clot or buildup of platelets causing a fibrin sheath. If the occlusion is suspected to be thrombotic, a medical officer needs to be informed as soon as possible, because if the clot happened to break off, it could cause harm to the patient. So we need to be really careful when dealing with thrombotic occlusions. Usually a trained professional can dislodge the clot in a safe way by using a drug called alteplase, and that breaks apart the fibrin sheath and the platelet buildup so that it doesn't travel anywhere else in the body. So occlusions can be partial or complete. So partial occlusions, you may be able to aspirate a little bit of blood, or you may be able to inject some saline or medications with slight difficulty, and that just means that it's not fully occluded at the end there, as seen in picture A there. But a complete occlusion is when you're unable to aspirate or inject any amount of fluid. And you can see that the fibrin sheath is encased completely around the catheter. The most effective way to avoid occlusions is to flush and positive pressure lock the device. And you want to be doing this before accessing and also when you're deaccessing any of the lumens. You also do it usually routinely every 8 hours if the lumen isn't in use. This just keeps it patent and stops any occlusions forming. Before flushing and locking a device, make sure that you're following your local policy and procedures because the equipment may differ and also the protocols may be different. So usually the equipment you'll need is a tray, so a kidney dish that you've disinfected with the correct solution. You'll need the appropriate PPE, non-sterile gloves. You'll need some alcohol wipes to scrub the hub or the bungs, and they need to have 2% chlorhexidine in them. 10 ml Luolox syringe, you'll need 2 per lumen. You can use 20 ml in some cases, but you cannot go any lower than 10 ml because the pressure will be too high. So 10 ml is usually the go-to. You'll also need 10 ml of sodium chloride, 0.9% ampule, and this is the recommended solution for flushing a CVAD. You'll need a blunt drawing up needle to ensure aseptic non-touch technique. And if you are going to be connecting any intravenous medications or lines, just have that handy. So once you have received consent from your patient after explaining the procedure, and you've got all your equipment ready to go, you've done all your checks, the next thing to do is to assess the patency. So following the 5 moments of hand hygiene and wearing the correct PPE and using aseptic non-touch technique. So you'll need to scrub the hub or the needleless connector for 15 seconds and make sure it's air dry. Attach empty 10 ml Luolox syringe to the needleless connector. Once the syringe is secure and attached correctly, you can then unclamp the catheter. You don't want to unclamp it beforehand, otherwise you could risk an air embolism. So once it's attached and you unclamp, you can then aspirate blood, and this is when you assess the ease of withdrawal. So you can see on the right hand side here, this is an example of a patency assessment classification. For a catheter to be classed as patent, it must be easy to aspirate at least 3 ml of blood, and it also needs to be easy to inject at least 1 ml of the flushing solution. If it was easy to aspirate at least 3 ml of blood from the line, you can then dispose of the syringe correctly in the yellow waste bin, the clinical waste, and then we can move on to the pressure lock. So while maintaining the non-touch technique, you maintain the sterility of the end of the needleless connector. If you do happen to contaminate that, you'll need to scrub the hub again with the 2% chlorhex and alcohol wipe for 15 seconds and wait for it to air dry again. Then you can attach the 10 ml syringe with the normal saline in it, and once it's attached completely, you can then start to inject or flush. So while flushing central lines, you use a pulsatile technique, so you pulsate. So usually 1 to 2 mils, and then you pause, 1 to 2 mils, pause, and this just creates turbulence in the line and is a good method at preventing any occlusion. And if we go back here to the classification, if there's any resistance or difficulty when you are injecting, this means that there is a potential occlusion. So the first thing you would do is you'd need to rule out any mechanical occlusions. So check the kinks in the line, assess the dressing. You may need to reposition the patient or the catheter. Ensure clamps are open, observe for drug precipitation. So if there's any lipids in the line, you might be able to see some TPN left over. You may try to remove the bungs and replace them with a fresh set and attempt to flush. If the issue is still unresolved, you'll then need to assess for tip migration. So has the external length of the catheter changed by give or take 2 centimeters? The patient might be reporting discomfort or dysrhythmias. You may need to ask them this. They potentially could be hearing a whooshing sound when it is flushed, and this just means that the catheter tip is not in the correct position. If there's any evidence suggesting that the catheter tip is migrated, then you will need to notify a medical officer, and a chest x-ray will be attended and reviewed. And if it is confirmed that the CVAD tip is in an incorrect position, you'll need to suspend use of the CVAD. You would need to make sure the treating doctor is aware and that the CVAD is repositioned by a trained professional. The CVAD would have to remain out of use until a trained professional, like a medical officer, has confirmed that it is now in the correct location and it is ready to be used. If there is no resistance while flushing, you may continue to flush using the pulse technique. And if it is a negative needleless connector that is in use, you clamp while injecting the final part of the solution, but leaving 1 to 2 ml in the syringe. The appropriate clamp disconnection technique differs depending on the type of needleless connector. So in this instance, if we're using a negative needleless connector, you need to clamp it while you're injecting the final portion. But you need to read your policies and procedures and ensure that you know the correct needleless connector that you're using, and just change your clamp disconnection technique depending on that. Positive pressure locking creates pressure inside the lumen, which reduces occlusions, particularly thrombotic clots, from forming. And make sure to document and hand over any occlusions that have happened throughout the shift or any concerns at all to the staff taking over. And just remember, always ask questions if you're unsure of something. It's always better to be safe and get a second opinion.